If a patient presents with recurrent abscesses, recurrent infections with catalase-positive bacteria and fungi, diffuse granulomas, and lung, skin, and liver involvement, I want you to think about chronic granulomatous disease or CGD. This is due to a X-linked recessive mutation of NADPH oxidase. So, because of this mutation of NADPH oxidase, there is decreased superoxide production. This impairs the neutrophil respiratory burst and decreases reactive oxygen species and inhibits phagocytic killing. So it's ideal to know that catalase-positive bugs include Staph aureus, Serratia, Nocardia, and Aspergillus. This one slide alone includes such high-yield information. So examiners could give you the clinical presentation of CGD and ask you about the inheritance pattern, which is something that they love to test. So it's important that you remember that CGD is X-linked recessive. Another thing is them testing whether you know the underlying cause of this. And this is, of course, due to a deficiency in NADPH oxidase. Another way that they like to test you on this topic is by describing an infection that is in a patient with CGD, and they ask you what bug is most likely would be found in this patient. And you'd have to be able to identify the catalase-positive microorganism. It's also very important to note that to definitively diagnose a patient with CGD, you can do the dihydrohordamine or DHR, probably didn't pronounce it properly, but the DHR test. This test, the DHR test, has largely replaced the nitroblue tetrazolium test or NBT test. So these patients may require prophylactic treatment with drugs such as trimethoprim, itraconazole, interferon gamma, and also the cell transplant can also be curative. X-linked agammaglobulinemia. So these patients typically present with recurrent sinopulmonary infections. They have decreased immunoglobulin production and lack opsonizing IgG, which leads to recurrent infections by encapsulated bacteria such as strep pneumoniae. So typically, these patients would have no such symptoms until about 6 months because the mother's antibodies protected them until that point. So to treat patients with X-linked agammaglobulinemia, you want to treat them with monthly IVIG. So for CGD, think about catalase-positive microorganisms, while for X-linked agammaglobulinemia, think about encapsulated bacteria, very high yield. Spinal muscular atrophy. So this is an autosomal recessive condition. So you can tell that I'm bringing up a lot of inheritance patterns because, again, examiners love to test this. You need to consider SMA in a 6-month-old with loss of motor milestones and fasciculations. You can also consider if it was an adult patient, you want to think about ALS in an adult with fasciculations. But if they're around 6 months old and they have fasciculations and loss of motor milestones, SMA. If a patient presents with inspiratory stridor that worsens when supine and they're around 4 to 8 months old, think about laryngomalacia. This is where they have a collapse of supraglottic tissues on inspiration, causing that inspiratory stridor. So to diagnose this condition, you want to do a flexible fiber optic laryngoscopy. And this diagnostic test can show an omega-shaped epiglottis. In most cases, inspiratory stridor spontaneously resolves by 18 months. So the treatment includes reassurance with close follow-up and to treat any symptoms of reflux. But if these symptoms are severe, then you may have to consider a supraglottoplasty. Vascular rings. These occur when an anomalous branch of the aortic arch or pulmonary artery encircles the trachea and esophagus. So this causes patients to have biphasic or expiratory stridor due to tracheal compression. They may also have breathing difficulties due to esophageal compression. Barium swallow can identify indentations of the esophagus. A contrasted CT scan or MRA can confirm the diagnosis. Rett syndrome. This is typically due to a gene mutation in the MECP2 gene. These patients can present with speech regression, loss of purposeful hand use, gait abnormalities, seizures, head growth deceleration, breathing abnormalities, sleep disturbance, and autistic features. Strabismus. So these patients typically have eye deviation, asymmetric corneal light, and red reflexes. Strabismus is typically a clinical diagnosis that you can arrive to by doing physical exam maneuvers such as corneal light reflex, a cover test, a cover and uncover test, and you will notice that they have an abnormal cover test. So if you do all of these physical exam maneuvers and you think that, hey, this patient definitely has strabismus, you don't just leave it at that. The first step in evaluation of these patients is a dilated fundoscopic exam to assess for secondary causes such as a retinoblastoma. Another high condition to know is estropia. This is due to a central vision loss and is the second most common presentation of retinoblastoma, right after leukocoria. So when you think about retinoblastoma, first consider leukocoria and then esotropia. Intraventricular hemorrhage. This is due to a rupture of fragile germinal matrix vessels. Risk factors include prematurity and very low birth weight. Symptoms can include the fact that they have no symptoms at all, they're asymptomatic, seizures or apnea, full fontanelle, and acute anemia. A cranial ultrasound is performed if asymptomatic or as routine screening if less than 32 weeks gestational age. Neonatal sepsis. This can be due to organisms such as group B strep, E. coli, and Listeria. Clinical features include temperature instability, poor feeding, jaundice, respiratory distress, including symptoms like tachypnea and grunting, CNS signs such as apnea and lethargy. And in these patients, you want to do basically everything to work them up. You want to do a CBC, urinalysis, cultures of the urine, blood, and CSF. Treatment includes parenteral antibiotics, typically ampicillin and gentamicin. So let's say that a patient presents with abdominal pain, hematemesis, diarrhea, shock, liver necrosis, and this all started after, they went into the medicine cabinet and they took some of their pregnant mom's medications or something of the sort. You want to consider at that point an acute iron poisoning. These patients also have anion gap metabolic acidosis, elevated serum iron, and radio-opaque pills on abdominal x-ray. And to treat these patients, you can use whole bowel irrigation, but the most common drug that you use is actually a chelating agent that binds free iron, forming a complex that can be renally excreted. Hyponatremic seizures. So you want to consider this condition in a child that is being treated for nocturnal enuresis. Recall that desmopressin is used to treat nocturnal enuresis, and this can cause hyponatremic seizures secondary to ADH analog oversecretion. Remember that desmopressin is an ADH analog. Desmopressin is also a very important drug in distinguishing between conditions such as central diabetes insipidus and nephrogenic diabetes insipidus. So it's a very high yield drug for you to know the indications and possible complications that patients can present with from using this drug. If a patient has a foreign body aspiration, you don't want to only consider choking and coughing as possible presentations. If the patient has cyanosis, if the history mentions a sudden onset respiratory distress, or even altered mental status, think about foreign body aspiration. In these patients, you'll hear focal, monophonic wheezing on the affected side. So it's typically unilateral. There will be diminished aeration of the affected side, inspiratory stridor, and even wheezing. Radiographic findings include hyperinflation or atelectasis on the affected side. You can even visualize the foreign body sometimes. Most aspirated foreign bodies end up in the right main stem bronchus. Exudative pleural effusion. This can be due to conditions such as a chylothorax, malignancy, empyema, or tuberculosis. A chylothorax is an exudative pleural effusion due to a disruption of lymphatic flow within the thoracic duct. A chylothorax is differentiated from other causes of exudative pleural effusion by its milky white color and elevated triglyceride levels. So a pleural effusion is basically excessive fluid in the pleural space. Once you see a pleural effusion, your next step is to think about, hey, is it transidative or an exudative pleural effusion? You can use the Leitz criteria to distinguish between them. But for a transidative effusion, it's typically due to conditions such as left-sided heart failure, cirrhosis, nephrotic syndrome, peritoneal dialysis, or even atelectasis. While an exudative effusion may be due to bacterial pneumonia, viral infections, pulmonary embolism, tuberculosis, and malignancy. A physical exam of a patient with a pleural effusion will reveal dullness percussion, decreased rest zones on the side of the effusion, decreased tactile firmitas. So to distinguish between a transidative versus exudative fluid, this requires measuring the pleural fluid levels as well as the serum fluid levels of substances like LDH and protein. So like I mentioned before, Leitz criteria is used to differentiate between transidative and exudative effusions. So if you notice a patient has a protein pleural over their protein serum is greater than 0.5 and that their LDH pleural over their LDH serum is greater than 0.6 and their LDH is greater than 2/3 of the upper limit of normal of serum LDH, then you want to think about an exudative transfusion. Well, rather a exudative effusion. What is the next step in management for a child with suspected anaphylaxis? Intramuscular epinephrine. So recall that epinephrine has effects on both the alpha and beta receptors. So the beta 2 agonism will cause bronchodilation, while the alpha 1 agonist will cause vasoconstriction, which leads to increased blood pressure and decreased airway edema. This is definitely one way that examiners like to test you on these receptors. What is the next step in management for a newborn with respiratory distress and hypoxia secondary to a suspected congenital diaphragmatic hernia? Endotracheal intubation. So it's very important that if a newborn with respiratory distress has congenital diaphragmatic hernia, that you do an endotracheal intubation and you make sure that you do not use a bag mask ventilation, because more bowel gas can exacerbate the pulmonary function. A gastric tube should be placed immediately after to decompress the stomach and bowel against the lungs. Neonatal respiratory distress syndrome. So this is respiratory distress due to inadequate surfactant levels. On chest x-ray, you can see diffuse granularity of the lung with a ground glass appearance. Gestational diabetes is a risk factor for neonatal respiratory distress syndrome because increased insulin prevents surfactant synthesis and lung maturation by interfering with cortisol. So think, high insulin can cause decreased surfactant, which will lead to NRDS. So treatment for these patients include early positive pressure ventilation, and the risk of NRDS may be reduced by administering maternal antenatal glucocorticoids. This stimulates fetal surfactant synthesis and secretion. So now a bonus question. Which pneumocyte creates surfactant? Is it type 1 or type 2 pneumocytes? Leave it in the comment section below. What is the recommended treatment for a child with a small parapneumonic effusion identified on X-ray with no respiratory distress? Oral antibiotics and outpatient follow-up. Another high-yield point is that in patients with subcutaneous emphysema secondary to severe cough, a chest x-ray must be obtained to rule out a pneumothorax. What is the next step in management for a patient that needs emergency fluid resuscitation and peripheral IV access cannot be obtained? Attempt intraosseous access. It requires less skill and practice than central line placement and is safer and faster. Now let's review some high-yield hematology concepts or topics. What is the likely diagnosis in a child with a history of sickle cell disease that presents with hypovolemic shock in the setting of left upper quadrant tenderness and an enlarged spleen? Splenic sequestration. So hypovolemic shock occurs due to the pooling of red blood cells within the spleen. So let's just remember these facts. If a patient has sickle cell disease, hypovolemic shock, left upper quadrant tenderness, and an enlarged spleen, think about splenic sequestration. Hydroxyurea is useful in the treatment of sickle cell anemia because it increases the levels of hemoglobin F to more than 15%. Increased hemoglobin F dilutes the amount of hemoglobin S, thus decreasing pain crises, the need for transfusions, and episodes of acute chest syndrome. What is the most common cause of pediatric stroke? Sickle cell disease. So I can't stress enough how high yield this slide is. So take a moment and commit these facts to memory. What is the likely diagnosis in a 5-day-old baby that did not receive perinatal care and presents with easy bruising with an elevated prothrombin time. Vitamin K deficient bleeding. So, previously known as hemorrhagic disease of the newborn, this deficiency occurs due to a combination of poor placental transfer, absent gut flora, immature liver function, and inadequate levels of vitamin K in breast milk. What is the likely diagnosis in a child that presents with scattered petechiae with isolated thrombocytopenia and enlarged platelets following a viral infection? Immune thrombocytopenia. This is very high yield. So if a patient, let's say that they had a upper respiratory tract infection, and then they present with petechiae, and you do blood work, and the only thing that's abnormal is that they have thrombocytopenia. Think about ITP. It most commonly occurs in children between the ages of 2 to 5 following a viral infection. In children with ITP, skin manifestations only require observation regardless of platelet count, as ITP is generally self-limiting. The treatment for ITP includes IVIG or corticosteroids. What is the likely diagnosis in a child that presents with short stature, hypoplastic thumbs, abnormal skin pigmentation, and aplastic macrocytic anemia? Fanconi's anemia. So this is due to a defect in non-homologous end joining or double-stranded break repair. Aplastic anemia may be caused by Fanconi's anemia, which occurs due to a DNA repair defect resulting in bone marrow failure. What is the likely diagnosis in an adolescent with a history of hemophilia A that presents with a gradual worsening pain and limited motion of his knee? Hemophilic arthropathy. So, with this recurrent bleeding, they can have hemosiderin or iron deposition, leading to synovitis and fibrosis within the joint. The risk is significantly reduced with prophylactic factor concentrates. First, we'll discuss the renal system. So, a Wilms tumor is an asymptomatic abdominal mass that does not typically cross the midline. The most common site of mets is to the lungs, and these patients are typically between the ages of 2 to 5 years. It's also associated with syndromes such as Beckwith-Wiedemann syndrome and as well as WAGR or Wager syndrome. In order to treat these patients, you want to do a tumor resection or nephrectomy, and also it might be required that you do chemotherapy and radiation therapy. The USMLE likes to present a scenario of a healthy 4-year-old that is generally just asymptomatic, but their parent was bathing or showering them and then they felt this mass. And on physical exam, there is a palpable painless abdominal mass that does not cross the midline. Why that is so important is because they typically want to confuse you between the Wilms tumor and a neuroblastoma. So the neuroblastoma can cross the midline, but in Wilms tumors, they typically do not cross the midline. And the best initial test is an abdominal ultrasound, while the most accurate test is a CT with contrast. What is the next step in management for a child that is found to have isolated proteinuria on urine dipstick? Well, that is to repeat the dipstick testing on 2 subsequent occasions. If the subsequent tests are negative, the diagnosis is transient proteinuria. If subsequent tests revealed continued proteinuria, then further workup is required. For the pediatric population, examiners love to test proteinuria in the setting of nephrotic syndrome, of course, but they also now like to test isolated proteinuria and transient proteinuria. So it's very important to know the differences between them and what's the next best step to do in these situations. So let's now compare nephrogenic diabetes insipidus versus primary polydipsia. Both of these conditions present with polyuria, polydipsia, and diluted urine. So this is typically where the urine osmolality is less than 300 milliosmoles per kilogram. So how can we differentiate between these two conditions if they have the same presentation or very similar presentation? Well, we can do a water deprivation test. And with the water deprivation test, we're basically just not giving the patient any water for a set period of time and then analyzing how the body reacts to it. We're trying to see why exactly is this urine dilute. Primary polydipsia is due to an excessive water intake, which suppresses ADH. Water deprivation test increases ADH and concentrates urine. So when you think of someone with primary polydipsia, think of someone who is just drinking a ton of water. And this excessive water intake causes dilute urine, polydipsia, polyuria, and what's happening is that the ADH is suppressed. So when the ADH is suppressed, we're not able to concentrate urine. But once you do the water deprivation test, the ADH then increases, and of course, the urine concentrates. In nephrogenic diabetes insipidus, this is due to a renal resistance to ADH. So it could be that the body is producing ADH, but we're just not detecting this ADH. So, we're still experiencing the symptoms of the polyuria, polydipsia, and dilute urine. However, once you do the water deprivation test, the ADH is increased, but the kidneys are resistant to the ADH. So our bodies are not able to detect this high or increase in ADH in nephrogenic diabetes insipidus. So the urine remains dilute in this condition. What is interesting though is that if you do a water deprivation test and the urine remains dilute, honestly, it could be between the nephrogenic diabetes insipidus and central diabetes insipidus. So at this point, you want to administer desmopressin to differentiate between the two. And desmopressin is an ADH analog. So if you give this ADH analog to patients with nephrogenic diabetes insipidus, what will happen is that the urine will still remain dilute because, like I said, in nephrogenic diabetes insipidus, the issues in the name is nephrogenic. Something is wrong with the kidneys. It's not detecting or responding to the ADH that is in the system. So giving the desmopressin analog will change nothing really for these patients. However, in patients with central diabetes insipidus, yes, they would have the same water deprivation test results. However, once you administer the desmopressin, they will start to concentrate their urine. In central diabetes insipidus, these patients have a complete or partial deficiency of ADH. So it's not that their bodies can't respond to it, it's just that their bodies aren't making it or making enough ADH. So once we give the desmopressin or ADH analog, then the urine will start to concentrate in central diabetes insipidus. If you like this type of content so far, please be sure to pop that like button, hit subscribe, and that notification bell so that you never ever miss another video like this. Type 1 diabetes. So these patients can present with symptoms like fatigue, polyuria, polydipsia, and signs of dehydration or weight loss. Children can present with this condition between the ages of 4 to 6 years old, or at early puberty. It has a bimodal onset in the pediatric population. And the weight loss or dehydration is due to excessive loss of glucose or water. So, of course, to treat these patients, we want to give them insulin. So, I just wanted to bring up this point because if you see polyuria and polydipsia, don't just think, diabetes alone. Think about, the primary polydipsia, the nephrogenic diabetes insipidus, essential diabetes insipidus. Think about all these different differentials and really analyze the information given to you in questions or clinical scenarios in order to lead to the right diagnosis or getting the answers correctly. Membranous nephropathy. So this can be suspected in an adolescent with features of nephrotic syndrome and a hepatitis B infection. When you're prepared for step 1 and there was a table on the different types of nephropathy and the associated conditions with like sickle cell disease, drug use in African Americans, this is still a very, very high yield concept to know. In membranous nephropathy, basically there is a formation of an antibody immune complex, and it can be secondary to infections such as hepatitis B or hepatitis C. It can also be secondary due to autoimmune diseases such as SLE and medications such as NSAIDs or even gold. So on electron microscopy, you can see a spike and dome appearance in membranous nephropathy. In focal segmental glomerular sclerosis, it's common in African American and Hispanic populations. It's also associated with sickle cell disease and HIV. Very, very high yield to know. In minimal change disease, it's the most common cause of nephrotic syndrome in pre-adolescent children, less than 10 years old. And this is a T-cell mediated injury of the podocytes. It can be associated with recent infections and immunizations, and rarely associated with Hodgkin's lymphoma. And we typically treat with steroids. What is the likely diagnosis in an African American patient that presents with painless gross hematuria with numerous intact red blood cells on microscopic exam? Renal papillary necrosis, and this is typically secondary to the sickle cell trait. So these patients have an intact red blood cells because it's not of a glomerular origin. And the relatively low partial pressure of oxygen in the vasa rectae of the medulla predisposes red blood cells to sickling, which increases the risk of papillary necrosis. Other causes of renal papillary necrosis to consider include diabetes mellitus, analgesics, and acute pyelonephritis. But if you see an exam question and they mention an African American patient and they had recurrent hospitalizations of chronic pain or even pneumonia, and they also are having painless gross hematuria with numerous intact red blood cells, think about the fact that this patient might have the sickle cell trait and they're experiencing renal papillary necrosis. If you see a question with a patient that has palpable purpura, arthralgias, and abdominal pain, I want you to think about Henoch-Schönlein purpura. This is also known as an IgA vasculitis, and patients are typically less than 10 years old, and these patients typically can present during the fall and winter months. It can be associated with preceding upper respiratory infection. So just remember, joint pain or arthralgias, colicky abdominal pain, hematuria, think about Henoch-Schönlein purpura. And when you do a physical exam, you might find symmetric, palpable, non-tender purpura on the buttocks and lower extremities. And this is typically the first sign of disease, and it may even spread from the lower extremities to the upper extremities. Physical exam may even reveal abdominal tenderness on palpation. To treat these patients, of course, you need supportive measures such as hydrations and address their pain. You can give them NSAIDs and also to treat with steroids if their condition is severe. Let's do a quick bonus question. Let's say a patient presents with fever, anemia, thrombocytopenia, renal failure, and neurological symptoms. What's the most likely diagnosis in these patients? If you said thrombotic thrombocytopenic purpura, then you are absolutely correct. Posterior urethral valves. This is the most common cause of urinary tract obstruction in newborn boys. Classic findings of prenatal ultrasound include bladder distension and bilateral hydronephrosis. This condition does not occur in girls. So if you see a presentation of a newborn girl and they have posterior urethral valves as a possible answer choice for whatever urinary symptoms they're experiencing, this would not be the answer. Vesico-urethral reflux. This is the likely diagnosis in a young girl that presents with recurrent UTI since birth, with bilateral focal parenchymal scarring and bluntal calluses on imaging.